Welcome to Lecture 3 in our Pharmacology series. So far, we have built on our vocabulary and learned how drugs are grouped into classes. Today, we follow a single drug on its journey through the body. This is the study of pharmacokinetics. And if you remember one phrase from Lecture 1, it's this: Pharmacokinetics is what the body does to the drug. That's different from pharmacodynamics, which is what the drug does to the body. Today is all about the body's side of that relationship. We will use a simple four-letter map called ADME, which stands for absorption, distribution, metabolism, and excretion. These are the four stages every drug passes through from the moment it enters the body to the moment it leaves. Along the way, we will look at different routes a drug can take to get in, why some routes act faster than others, and the key factors that speed a drug up or slow it down. We will also cover a few practical concepts like onset, half-life, and therapeutic range, which explain why timing and dosing matter so much. Throughout, keep asking yourself one question: how does this affect the way I care for a patient? Because pharmacokinetics is not just theory. It explains why you tell one patient to take a medication with food and another on an empty stomach, and why timing a dose correctly can be the difference between a drug that helps and one that doesn't. Here are our 5 goals for this lesson. First, define pharmacokinetics and describe the ADME process so you have a clear map of a drug's journey through the body. Second, identify the common routes of administration and understand how the route a drug takes affects how quickly it starts to work. This is very practical because you will help prepare and administer medications by several of these routes. Third, explain each of the four ADME stages: absorption, distribution, metabolism, and excretion at a level that makes sense for patient care. You do not need to be a pharmacologist, but you should understand the big picture of where a drug goes and how it leaves. Fourth, describe a few key timing concepts: onset, half-life, and therapeutic range, because these explain why dosing schedules exist and why staying within a safe range matters. Fifth, apply these ideas to your own role as medical assistant. By the end, you should see how pharmacokinetics shapes real tasks, such as giving clear instructions about food and timing, recognizing when a drug may be building up in a patient, and knowing which patients need extra caution. As always, connect each concept to a patient you might see, because that is what turns these four letters A, D, M, and E into safe, confident practice. Let's define our subject clearly and lay out the map for the whole lecture. Pharmacokinetics is what the body does to the drug from the moment it enters until the moment it leaves. Notice the direction of that sentence. The body is the actor and the drug is being acted upon. That is the opposite of pharmacodynamics, where the drug acts on the body. Keeping that direction straight will save you from confusion. On the right is our map, the four stages of ADME, and we will spend the rest of the lecture walking through them in order. A is for absorption, the stage where the drug enters the bloodstream. Before a drug can do anything, it has to get into the circulation. D is for distribution, where the drug travels through the blood to reach the body tissues where it's needed. M is for metabolism, where the body breaks the drug down, and this happens mainly in the liver. Think of metabolism as the body starting to process and dismantle the drug. E is for excretion, the final stage, where the drug and its breakdown products leave the body, mainly through the kidneys and the urine. Picture the whole journey as a road trip. The drug gets onto the highway through absorption, drives around the body during distribution, gets worked on in the liver during metabolism, and finally exits through the kidney during excretion. Every drug your patients take makes the same trip, and each stage can be sped up or slowed down, which is exactly what we will explore next. Before a drug can begin its ADME journey, it has to get into the body, and there are several routes it can take. We group them into four main categories. The first is enteral, which means through the digestive tract. The most common example is oral, a tablet or liquid swallowed and absorbed in the stomach and intestines. Also considered enteral are sublingual, placed under the tongue to dissolve, and rectal. The second category is parenteral, which means by injection, bypassing the digestive tract. This includes intravenous or IV, straight into a vein, intramuscular or IM, which goes into a muscle, and subcutaneous, which goes into the fatty tissue just under the skin. You will prepare and, depending on stage and setting, administer several of these. The third category is topical and transdermal, applied to the skin or mucous membranes. This includes creams and ointments, eye and ear drops, and medicated patches that deliver drugs slowly through the skin over hours or days. The fourth is inhalation, breathed directly into the lungs, such as an asthma inhaler or a nebulizing breathing treatment. So why does the route matter so much? Because it determines how fast, and how completely a drug is absorbed, which is our next topic. It also affects what you teach the patient. A sublingual tablet should not be swallowed. Eye drops must stay clean and sterile, and a patch goes on clean, dry skin and is rotated to a new spot. Matching your instructions to the route is part of safe practice. Not all routes work at the same speed, and understanding this helps you set patient expectations and recognize how urgent a medication is. Onset simply means how quickly a drug starts to work, and the route has a powerful effect on it. Look at this table, arranged from fastest at the top to slowest at the bottom. Intravenous is the fastest of all because the drug is placed directly into the bloodstream and skips absorption entirely. Onset can be seconds to minutes, which is why the IV route is used in emergencies. Inhalation is also very fast because the lungs have an enormous surface area and a rich blood supply, so an inhaled medication can act within minutes. That is exactly why a rescue inhaler works so quickly during an asthma attack. Intramuscular and subcutaneous injections are moderate. The drug is deposited in a muscle or fatty tissue and absorbed from there over minutes to about an hour. Oral is slower, generally around 30 to 60 minutes, because the drug must travel through the digestive tract and be absorbed before it reaches the blood. Topical or transdermal routes are usually the slowest, often by design, releasing drug gradually over hours or even days, like a patch that lasts 3 days. Two practical points for you. First, this ordering explains why a provider chooses a particular route for a patient's particular need, urgent versus steady. Second, when you educate a patient, it helps them understand why an oral pain pill does not work instantly, which can prevent them from taking extra doses too soon. Now we start walking through ADME, beginning with the letter A for absorption. Absorption is the movement of a drug from where it is given into the bloodstream. Until a drug is absorbed into the blood, it can't travel to where it's needed, so absorption is the gateway to everything that follows. On the right are the main factors that affect how well and how fast a drug is absorbed. The route matters most, and remember that an intravenous drug skips absorption entirely because it goes straight into the blood. The drug form matters too. A liquid or a rapidly dissolving tablet is absorbed faster than a hard, coated tablet that has to break down first. Food in the stomach is a big one, and this is why instructions about taking a medication with or without food exist. Food can speed absorption, slow it down, or even block it for certain drugs, so following those directions changes how well the drug works. Blood flow to the absorption site also matters, since a well-supplied area absorbs faster. Finally, look at the box on the lower left, the first pass effect. When a drug is taken orally, it is absorbed from the intestine and carried first to the liver before it reaches the rest of the body. The liver can break down or metabolize some of the drug right away, which reduces how much active drug actually makes it into the circulation. This is one reason an oral dose is often larger than an equivalent injected dose. You don't calculate this, but understanding it helps you appreciate why route and form are chosen very carefully. The second stage is distribution, or the letter D. Once a drug is absorbed into the bloodstream, distribution is how it travels through the blood to reach the tissues and organs where it needs to act. Think of the bloodstream as the delivery network carrying the drug to its destinations. There are four ideas worth knowing here. First, reaching the tissues. The blood carries the drug throughout the body, and the drug leaves the blood to enter the tissues where it works, such as an antibiotic reaching the site of an infection. Second is protein binding. In the blood, some of the drug attaches to proteins, mainly albumin. Here's the key point. Only the unbound, free portion of the drug is active and able to do its job. The bound portion is like a reserve, held in the blood until it's released. This becomes important in patients with low protein levels, where more free drug may be available than expected. Third is barriers. The body has special protective barriers, most famously the blood-brain barrier that shields the brain and the placenta that surrounds a developing pregnancy. Some drugs can cross these barriers and some cannot, which matters a great deal in pregnancy and with medications meant to act on the brain. Fourth is body composition. How much fat and water a person has affects how a drug spreads out, and this differs with age and body size, which is one reason doses are sometimes adjusted for children, older adults, or by weight. You won't calculate the distribution, but recognizing these ideas helps you understand why the same drug can behave differently in different patients. The letter M represents the third stage, metabolism. Metabolism is the process by which the body chemically changes the drug, and this happens mainly in the liver. The general purpose is to transform the drug into forms that are easier for the body to remove. Look at the result box on the lower left, because there's a very important nuance here. For most drugs, metabolism turns the active drug into an inactive form, essentially winding it down so it can be cleared. But for some drugs, the opposite happens. The drug is given in an inactive form, and the liver converts it into its active form, which then does its therapeutic work. These are sometimes called prodrugs. Well, either way, the liver is the body's main processing plant for medications. On the right are factors that change how fast metabolism happens, and they matter clinically. Liver health is central. If the liver is damaged by disease, it processes the drugs more slowly, so a drug can build up to higher levels than intended. Age matters too. Infants have immature livers, and older adults have slower liver function, so both groups often process drugs more slowly. Drug interactions are a major factor. One drug can speed up or slow down the metabolism of another, which changes its levels. And this is a big reason accurate, complete medication lists are so important. Even certain foods can interfere. Grapefruit and grapefruit juice are the classic example because they can block the breakdown of some drugs and cause them to build up. When you gather a thorough medication and history, including supplements, you are helping the provider avoid these hidden interactions. The final stage is excretion, the letter E. Excretion is how the drug and the byproducts left over from metabolism finally leave the body. The star of this stage is the kidneys, which are the main route of excretion. Most drugs and their breakdown products are filtered out of the blood by the kidneys and leave the body in urine. This leads to a crucial clinical point. If a patient's kidney function is reduced, which is common in older adults and in people with kidney disease, drugs are cleared more slowly and can build up to dangerous levels. That's why providers often adjust doses based on kidney function and why kidney lab values matter so much in medication safety. Besides the kidneys, there are other exit routes. Some drugs are removed by the liver into bile and then pass out of the body in stool. A few substances, such as certain anesthetic gases, are inhaled through the lungs, and small amounts of some drugs can leave in sweat, saliva, and importantly, breast milk, which is why nursing mothers are counseled carefully about medications. For your role as an MA, the big takeaway is the connection between the kidneys and drug buildup. When you room patients, especially older adults, and you see notes about reduced kidney function, understand that their medications may need extra care. And when a patient reports symptoms that could signal a drug accumulating, such as increasing drowsiness on a stable dose, that's worth documenting and reporting. Excretion completes the journey, and now the cycle is ready to begin again with the next dose. Now that we've followed the full ADME journey, a few timing concepts pull it all together and explain why dosing schedules exist. The first card covers onset, peak, and duration. Onset is when a drug first starts to work, which we discussed with routes. Peak is the point of its strongest effect when the drug level in the body is at its highest. Duration is how long the effect lasts before it wears off. These three describe the life of a single dose from start to finish. The second card is half-life, one of the most useful concepts in pharmacology. Half-life is the time it takes for the amount of drug in the body to fall by half. Its practical value is that it guides how often a dose needs to be repeated. A drug with a short half-life leaves quickly and may need to be taken several times a day, while a drug with a long half-life can be taken less often. This is the science behind why one medication is once daily and another is every 6 hours. The third card is therapeutic range, sometimes called the therapeutic window. This is the sweet spot where the drug level is high enough to help the patient, but low enough to remain safe. Below the range, the drug doesn't work. Above it, there are risks of toxicity. Some drugs have a wide, forgiving range, while others have a very narrow one and require careful monitoring, sometimes with blood level testing. For you as an MA, these concepts explain why taking medications on schedule matters, why doubling up to catch up can be dangerous, and why some patients need regular lab monitoring, all of which you can reinforce with patients. A natural question you might have is why the same medication at the same dose can affect two people so differently. The answer is that several patient factors change pharmacokinetics, and recognizing them helps you understand who needs extra caution. The first one is age. Infants have immature organs, and older adults often have slower liver and kidney function, so both groups may absorb, process, and clear drugs differently from a healthy young adult. This is why pediatric and geriatric dosing frequently differs. The second is pregnancy. As we saw with barriers, some drugs cross the placenta to the developing baby, and some enter breast milk. So medication during pregnancy and breastfeeding are chosen with very special care. Whenever you room a patient of childbearing age, confirming pregnancy status and breastfeeding, when relevant, is part of safe practice. The third is organ function. especially the liver and kidneys, the two workhorses of metabolism and excretion. When either is impaired by disease, drugs are cleared more slowly and can build up, so doses are often reduced. The fourth is drug interactions, where one drug, an over the counter product, supplement, or even food can change how another drug is absorbed, metabolized, or excreted. This is the single biggest reason a complete and accurate medication list matters, and gathering that list thoroughly is squarely your responsibility. When you notice a patient falls into one of these higher risk groups, your careful history taking and documentation give the provider what they need to dose safely. Let's bring this all together so we can make it practical for your daily work, because pharmacokinetics quietly shapes several of your core tasks as MAs. First, support correct timing, because concepts like half-life determine dosing schedules. You help patients understand when and how often to take a medication, and you reinforce that doubling up to make up a missed dose can be unsafe. A simple, clear explanation prevents accidental overdoses. Second, explain food and route instructions. Absorption depends on these, so you teach patients whether to take a drug with or without food, whether a tablet can be crushed or must be swallowed whole, and how to correctly use a patch, an inhaler, or eye and ear drops. Correct technique is often the difference between a medication that works and one that does not. Third, monitor for effect and buildup. Because organ function and interactions can cause drugs to accumulate, you stay alert to reported symptoms that might mean a drug is not working or is building up, such as new drowsiness on a stable dose, and you document and report them. Fourth, gather a complete history. Since interactions are such a common problem, you record all medications, including over the counter products, supplements, and relevant foods, so the provider can spot and avoid interactions. Notice that every one of these stays firmly within your scope of practice as a medical assistant. You are not adjusting doses or diagnosing. You are timing, teaching, observing, and documenting. And those four actions make you a genuine safeguard in the medication process. In our next lecture, we'll move from how drugs behave to how they are controlled with prescriptions, over the counter products, and controlled substances. Let's summarize what we learned in this lecture. Pharmacokinetics is what the body does to the drug, captured in the four letters ADME: absorption, distribution, metabolism, and excretion. The drug enters the blood through absorption, travels to the tissues through distribution, is broken down mainly by the liver through metabolism, finally leaves mainly through the kidneys through excretion. We learned that the route of administration strongly controls onset, with intravenous the fastest and topical or transdermal the slowest, and that many factors, including food, organ function, age, pregnancy, and drug interactions, change how a drug moves through the body. We added the timing concepts of onset, peak, and duration, the half-life that guides how often to dose, and the therapeutic range that keeps a drug high enough to help and low enough to stay safe. And we tied it all to your role as a medical assistant. You support correct timing. You teach food and route instructions. You monitor for effect and a buildup, and you gather a complete history, all within your scope of practice. Here are the references I used to put this lecture together. Feel free to check any of them out for more information.